Good afternoon, everyone, and thank you for joining us for this week's National Bleeding Disorders Foundation, formerly National Hemophilia Foundation, Wednesday webinar. My name is Fiona Robinson, and I am the series host. Today, we have a webinar panel that's going to discuss the I'm fine mentality and whether entrenched resiliency might prevent people with bleeding disorders from living more fully. We really encourage you to ask any questions you may have today. The panel is looking forward to making them part of their discussion. You can ask your question by using the Q&A feature at the bottom of your screen at any time during the webinar. We will monitor these questions, and following the initial discussion between panelists, we'll put your questions to them. This webinar is being recorded and will be available to the community beginning on Friday, October 13th. It is my very great pleasure to introduce the chair of today's panel. Patrick James Lynch is the CEO and founder of Believe Limited and the host of the popular podcast, Bloodstream. I'll turn things over to Patrick now. Thank you very much for joining us today and let you take things away.
Well, thank you, Fiona. Thank you to the NBDF and to the Wednesday webinar sponsors for supporting this series and in particular today's discussion on the I'm fine mindset. My name is Patrick James Lynch. I'm a person with hemophilia, a content producer and filmmaker. And I just want you to know right up at the top, I'm fine. Really, I'm fine. Most of us know when we hear that or say it, that it's not actually true. At best, it's incomplete. So why do we say it? What is it masking? What is it preventing? What does it enable? What are my other options? Personally, over the last few years, I have become acutely aware of how a life lived with constant adaptation and adjustment set me up to accept more hardship, difficulty, and suboptimal conditions across all areas of my life. I think back to how often I've stiffened my lip, grit my teeth, and charged ahead, regardless of how I was actually doing. How many people with hemophilia, like me, have underplayed pain, suffering, and disability so that we wouldn't miss something we cared about or wouldn't be judged by someone we cared for? I'm fine. Since I was a little kid, I felt like I couldn't even trust my body to be a stable, reliable component of my life. Now I'm supposed to trust you? I'm fine. Changing jobs and changing insurance plans and having to explain bleeding disorders to yet another customer service representative? I'm fine. My regimen is working well enough. Sure, I can't do this or that, but if it ain't broke, don't fix it, right? I'm fine. It could be worse. There are lots of good jobs that involve sitting down and using computers. My love of physical work and attraction to manual labor probably needs to go. I'm fine. The goal of the next 54 minutes or so is for all of us, my fellow panelists, and all the attendees here to engage in an open dialogue about what the I'm fine mindset means, how it plays out in our lives, and how it impacts our total well-being as people living with bleeding disorders. Now, in a minute, I'm going to introduce each panelist and give each of them a chance to share their top thought, or at least their first thought, as it relates to I'm fine. And after we've heard from each, I'll prompt additional discussion with some questions while I stay aware of questions and comments coming in through the chat. So to Fiona's earlier prompt, please feel free to start submitting questions or comments for consideration as soon as you feel motivated, and we'll try to get to all of them by the end of the hour. Now, before I go to the extraordinary group of patient advocates that we've gathered here, I'd like to start with Dr. Mike Recht, NBDF's Chief Medical Officer, who I am very thankful is with us today. So Mike, and we have agreed, we're all going with first names, so nobody has to call me Mr. Patrick. I don't know what else you would call me, but Patrick, Mike, thanks for being with us. In my layman's brain, it could be easy for hematologists and clinical professionals to dismiss this I'm fine mindset conversation, to underappreciate the impact that mindset can have on health outcomes, especially when we think about patients living with chronic and rare disorders. So from your point of view and based on your experience, how does the medical community appreciate how insidiously powerful chronic resilience and entrenched thinking can be when it comes to health outcomes? and you may be on mute.
I really did not want to be that person today. I really didn't want to be that person.
You did it for all of us.
I appreciate so much the opportunity to participate in today's panel. As a clinician, so even though I am NBDF's Chief Medical and Scientific Officer, I still do see patients, children and adolescents and young adults, and sometimes even adults with inherited bleeding disorders through the treatment center at Yale University. And this mindset, the resiliency, the I'm fine mindset, has some real powerful positive aspects on how people care for themselves, care for others, but also can have throw up some roadblocks, throw up some challenges in being able to obtain the best individual-centric, state-of-the-art, culturally sensitive care possible. You know, as a pediatric hematologist, I am so lucky that I get to see those kids and families that I serve, I get to see them grow up. And so I get to know them from a very early age into early adulthood. And, you know, one of my practices is I have stopped walking in the room and saying, "Hey, how you doing?" Because I know that answer is going to be, "I'm fine," right? No one really wants to reveal or disclose issues to doctors or other providers, even if I've known them for their lifetimes, that they want to project this idea that they're doing okay.
Right.
So how do I know this? So I've been involved in a bunch of longitudinal natural history studies, looking at how people with inherited bleeding disorders do over the years based on the kind of therapy that they're getting. And what we saw, for example, in a study that we did with the American Thrombosis and Hemostasis Network, Athens 7, which looked at people with hemophilia, we took the opportunity to ask people some validated patient-reported outcome tools. And we saw that over 40% of people with hemophilia endorsed having chronic pain. Almost 30% of people with hemophilia had symptoms of anxiety and depression. And yet, when you ask the question on a scale of 1 to 100, how are you doing today? The answer was completely the same as the general US population. So the average score of how are you doing today was 92%, right? So people are essentially, that's a numerical way of saying, "I'm fine."
Right.
Even though they are experiencing these adverse impact of having their underlying condition.
And correct me if I'm wrong, Mark, but I believe that's what we know as the disability paradox. And I wonder if you could maybe extrapolate on what that little bit of data really says about our community.
Yes, great to see everyone today. The research that I've been involved in over the last few years really has focused on this question. I've never known normal. I had hemophilia since I was born and faced all the challenges. So I've constantly adapted. I've been told I can't do this, I can't do that. Just a little bit of just sort of insidious, you give up things, but you learn to be happy. I mean, we all have things in life that reward us and we have different choices. But the concept of the disability paradox is well established, and it's been pretty heavily researched in hemophilia. And it really means, if you pick up on what Mike's saying, that if you measure patient-reported impact of conditions or the lasting disabilities that come with something like hemophilia, it can be counterintuitive that individuals with hemophilia may, in fact, score the quality of their life higher than the general population, in spite of living with multiple comorbidities, multiple limitations in range of motion and joints, that they've had to give up perhaps what their career goal was as a child to find something else to bring them satisfaction. So they do in fact score their quality of life as good or excellent. But when observers that would be given or asked to say, what would your quality of life be if you had these limitations, they score it significantly lower. And that challenge really is one that I do think sort of self-reinforces the notion. It's hard for us to visualize, what really is unimaginable, because we don't really give up something. We've just sort of slowly lost it over time. We've learned to be content. So I think part of the challenge is, when I go into my hemophilia treatment center, as Mike was talking about, and historically, the doctor, the care team would say, how many bleeds have you had last year? And I might say 5, or I might say 0. If I say 0 or a low number, they'll say, that's great, keep doing what you're doing. But that doesn't mean that I haven't given up life, that I'm now just sitting on the couch or have a desk job and I'm not really doing what I want. So we need to find a way to have that conversation to break down that counterintuitive paradox. And so I think the evidence is well grounded. And I think that it's not just a US phenomenon, it's not just a hemophilia phenomenon, but we really need to understand it if we're going to persuade payers to actually want to pay for something more and better, so we don't have to give up on those things. So I think Mike opened it up well, and I think sort of the community knows they're there, but it maybe isn't in the forefront of our consciousness, because we do think we're fine, which is actually great. The human body is adaptable, so I'm not wallowing and worrying all day, but it doesn't mean it has to be that way.
And thank you for saying hello, by the way. And that is Mark Skinner. I should have done a bit more of an appropriate introduction for you, the president and CEO of the Institute for Policy Advancement, who's held a bajillion other titles in this community as well. So we've got some good background there on some of the data that has been collected, what the data suggests. Mike gave us some good insights from medical scientific point of view. Connie Montgomery, retired occupational therapist. I'm going to find ways to just slide these little bits from your bio into my introduction like that. Outstanding advocate for this community, for the rare inherited blood disorders community in particular. In our pre-meeting work, you shared something that I'd like to cite, Connie, to give you an opportunity to extrapolate. But you had mentioned, as a young Black girl, now woman, I never felt like there was room for me to be anything else but fine. What do you mean by that?
Well, when you come from the background here in the Southeast, where I come from, when you're from a single parent home that became a single parent home after 14 years of marriage, and watching my mother raise 4 girls on her own and working 2 to 3 jobs at all times, then you come from the mindset that I come from and behaviors that followed, which is, I am fine, I don't have time to be anything else, and I'm not going to cause my mother any additional stressors or worry by being something else. As well as culturally, we keep our family business in the home. What happens in the family stays in the family. We won't be giving anyone else any opportunity to think less or anything else of us, because there were so many stigmas and taboos associated with, of course, bleeding issues and any type of health issue in a lot of the Black communities. Those things were sort of put on the back burner, and we trudged forward in my family. And that was my experience. So didn't have time to be anything else but fine.
There's a lot in there that I'm sure we'll come back to. Ivan Garon, I want to bring your voice in as well. You and I are 2 guys with hemophilia about the same age, living in Southern California. I think there's a lot of ways in which I'm fine has probably played out in our lives quite similarly. So two parts. One, I'm curious, what does come to mind for you when you first heard about this panel, this discussion, when you think about that mindset, what comes to mind? And then as a follow-up to that, I know you as a parent in a lot of ways too, and I've interacted with your family. I've seen you as a dad. I'm curious how you think about I'm fine as it relates to role modeling emotional health, what good looks like for your family. So wherever you'd like to go with that, Ivan, the floor is yours.
Thank you, Patrick. Yeah, as a Hispanic with hemophilia, I grew up in a household where the dad basically called all the shots and you have to be a man, right? A macho. So showing any kind of emotions is somewhat of a weakness. And so, when we're born, we're already born with a disadvantage in a way. We have to be very careful with the things that we do. I was, since my mom was a spontaneous mutation, I was one of those kids that wore the helmet, knee pads, elbow pads. So I was automatically different from everybody else. And as I got older, I was a big active kid, so I wanted to play sports, and my dad tried to put me into sports, soccer. There was no prophylaxis at the time, so I ended up having multiple bleeds on my right ankle. By the time I was 14, I ended up with arthritis. I hated hemophilia, and I never wanted people to think any less of me. So if I was limping, they asked me, "You all right?" "I'm good." It comes down to almost pride, ego, and sometimes even denial. You don't want to accept that you have hemophilia. You don't want to infuse, so it was very difficult for me growing up until I hit the age of 21. I already had my 2 kids, but I sprained my left ankle, which was my good one, and I didn't want it to get like my right ankle. So I was forced to take good care of myself and be compliant with my medication, but I was still depressed because I couldn't be an athlete. I couldn't do the things that I wanted to do. At least I thought I couldn't, right? And that's what kept me away from the community until my daughter had her first cycle. Then I realized that it was different. Women do have hemophilia, and it's completely different from men. So it got me back into the community to try and understand what women go through. And that also helped me understand myself as a patient, what I can do to get better and have a better quality of life. But I'm not gonna lie, the depression's there sometimes, but you got to learn to work through it. That's why I believe community is very important. And because of being a father, trying to be a role model, I also try my best to be as positive as possible with all the situations that are going on. And I do tell my kids, it's okay to, feel a certain way and share it. If you're not feeling good, talk about it. We can find ways to motivate you, to inspire you, to help bring you back up, because that's what I needed when I was growing up, and I didn't have that. So it was very difficult for me until I surrounded myself with good, positive people. I started realizing we can get through this stuff together if you set your mind to it.
Thank you, Ivan. Really appreciate that. I actually want to use some of what you shared to go to Mosey next, and then Paxton will take us home in the introduction whip around here. Mosey, to state the obvious here in his way by means of introduction, Mosey Williams is also a fellow blood brother with hemophilia in California. He's also the licensed clinical social worker at a treatment center up in Northern California, having taken over for the legend Dana not too long ago. Mosey, Ivan and Connie brought up cultural components that contribute to the I'm fine mindset. There's, of course, family, that microculture, the more macro culture that you exist within. This is a dynamic topic. As a social worker, you have opportunity to sit across from patients and families to talk through some of this stuff, to try to dig at what might be preventing someone from making choices that would better their healthcare. So I want to give you the same opportunity as everybody, address the I'm fine topic from a broad perspective as you would, but then specifically for you and on the heels of those last 2 contributors, how do you work through some of those cultural, familial, more difficult, frankly, from my perspective, barriers to optimal healthcare when you have that rare opportunity to sit across from someone face to face, or perhaps on a Zoom?
Thanks, Patrick. And I'm privileged to be a part of this discussion. And there's so many dimensions to I'm fine. And I can definitely, what Ivan said, what Connie said, resonates with me as well as from the patient side, and having been in school and having to justify for the principal that I hadn't bleed and I wasn't being abused at home. So you know what? I'm not going to talk about bleeds anymore in school. I'm fine. I see that part. And as a social worker, that statement, asking a patient, well, how is this going? Oh, it's going well. Part of that sometimes is because we go through so much change. If a patient has been with a bleeding disorder, has been through medications that did work, having an inhibitor, or this medication didn't work for them, trying a different one, finally finding a regimen that works. And you know what? They're going to stick with this. Now, there are other options that are, new treatments that have come out, but they're going to stick with the one that works because, I don't want to take a chance. Maybe this won't work again. What if that doesn't work? I'm fine where I'm at. And, in terms of, we can think about the hierarchy of needs. So, before I'm trying to be the best that I can be, I have to be safe first. I have to be okay where I'm at. That's one part of it. Another part could be, I'm thinking of a song by Genesis and Phil Collins, please don't ask me how I feel fine. Because I don't want to unpack all of this right now, because it's going to keep coming out and I won't be able to stop. I have to, and to go through this process and the grieving and all the things. It's heavy to think about. So I don't want to go into that. And unfortunately, our culture we greet people by saying, how are you doing? So there really isn't the time. And I had a friend that asked someone that, and then they said, do you really want to know how I feel? Because you just say, hey, how you doing? So there isn't the space, and then the person not having that space, not feeling comfortable to open up to, because sometimes a clinic visit is, it's an hour, each provider has 15 minutes. And so all these things are some elements to why, we're not going to necessarily unpack all of this. We're just going to sally forth and go and continue on and find some way to deal with it.
Thank you, Mosey. Such rich, every one of these is like enough to just go for 50 minutes. So Paxton, I want to give you the opportunity to get your voice. And I also want to say hello to you, because I think this is the first time you and I are actually meeting. I have the pleasure of knowing these other folks here. So nice to meet you. Thanks for doing this. Same as everyone else, what comes up for you firstly? And then I have a follow-up for you, but I'm going to hold that and give you the chance first to respond to the broad question, Paxton. Go right ahead.
Absolutely. Yeah. So again, thank you for having me as well. And nice to meet you. So for me, when I first heard, the I'm fine mindset in this, like you said, our pre-meeting work, my mind, because of my own background, goes to specifically the lens of being a woman with a bleeding disorder and also being the patient of a rare bleeding disorder. So I have a rare platelet defect and also just some unresolved bone marrow and hematological abnormalities that haven't been tied together despite, valiant efforts on all sides. And I think the biggest thing, especially with the unknown and the undiagnosed condition group of people, is that it's just out of sight, out of mind. I don't have a name for it. I don't have a box to put it in, a label for it, a category for it. So you kind of can convince yourself that, it's not in my records in an official capacity, then it's fine. I don't need to worry about it. And then I think for the rare side of things, we get into the gray area of oftentimes with specific disorders, people who haven't heard of them or maybe haven't been exposed to them before have the preconceived notion of, oh, well, that's mild, so you're fine. That's a mild bleeding disorder. That's not something that is severe. It's not something that would impact you on a day-to-day basis. But I try to reiterate that these bleeding disorders, it's a very individualized experience, so how it expresses itself in one person could be very different than another patient of the same disorder. So you can have severe ranges too. It can be a mild bleeding disorder, but if somebody is exhibiting it in the severe range, like on a molecular level, then they might bleed, in a severe way too. So those are my two biggest things. I think you can just kind of get into a slippery slope of convincing yourself you're fine and not giving yourself the space to be anything other than fine.
Very well said. Paxton, you are also, as I think the youngest member on the panel, we are going to take the first question from our audience to the person who maybe is closest to this. But Brendan has a question about what can parents and caregivers of teens and young adults do to normalize the I'm not fine conversation. And I appreciate the inclusion of the word not there. So Paxton, what's your take on that? Do you have moments when you think back to growing up, something that your parents did or you would like for them to have done, or any lived experience that helps inform something that might be of value to Brendan?
Yeah, I think, and it's almost counter to like the question, but from the caregiver and parent perspective, being able to encourage your child, even at a young age, to advocate for themselves. That's something that I'm immensely grateful for in terms of my experience with my parents and navigating the bleeding disorders, seeing and being relatively late to it. I was diagnosed around 12, 13. But I mean, we just had the conversation and said it like it was. It wasn't something that we danced around. I think part of that is because, when you're a woman or a girl with a bleeding disorder, you naturally have, things that will come up that will make that more obvious, that you have an issue. So I think just not shying away from the topic, and being able in that safe space of a home with whoever their person is, whoever their adult is, being able to have that conversation. And then as you're navigating that and becoming a more and more mature person, aging and becoming a teenager, ultimately a young adult, that kind of thing, really empowering them to advocate for themselves. And you can be fine in the sense that you're not fine. And if that makes sense, being able to acknowledge this is something that I individually have to deal with that my peers might not have to. But here are the things that I can do to help to make myself feel better, to mitigate the implications of it on my everyday life. And yeah, advocating for yourself, I think even as a child, is a really good skill.
I agree. And I think it directly fights that I'm fine mindset thing, because it's literally asking oneself, like, identify the need and advocate for it, as opposed to what I have to still work against, which is ignore the need as best I can, keep doing the thing I want to do until the need gets so great that it takes me out and forces me to address it. Like, that's not optimal. Let's go to Mike, and then I have something for Ivan. Mike.
So as a clinician, I know that it takes significantly longer to come up with a diagnosis for people with rare disorders. And we know that women with bleeding disorders, their journey can be 12 to 15 years between the time they present and they get an actual diagnosis. So a question I have for both Connie and Paxton is, how does the I'm fine mindset get in the way when you're sitting in a clinic room and the doctor is saying you're fine, and you're saying, you really have to say, no, I'm not okay. There is something going on that needs to be investigated.
Connie, you want to take the first crack at that?
Yeah, well, for me, I'm fine became a state of mind and a state of being, existence, that at some point could no longer be supported mentally, emotionally, or physically. It was just too exhausting and physically draining to manage day to day, first and foremost, as a woman with a bleeding disorder, next, as a Black woman with a bleeding disorder, and being located where I was in the South and where I am. I needed to own the fact that I was not fine. Then I needed to be comfortable with being vulnerable and sharing that with healthcare practitioners, regardless of what they were saying to me, being honest about how I was feeling and what I was experiencing, and regardless of what the levels state, because I have factor 7 deficiency. And so many times they'll look at the levels and not the symptomology of the patient. So I've had to do that work. And what I found was denial and then depression, neither were good coping mechanisms. And humor and secrecy, that certainly, didn't get me far. The humor got me a few laughs, but the secrecy was just too much of a burden and pain to bear. So, resilience and strength came from being bold enough to seek care that I needed in whatever area I needed it. And I had to change and really alter my mindset and behavior and implement better healthcare practices for myself. And then I had to self-advocate for myself. And then, of course, I got into self-advocating for others as well. We just have to step forward and feel empowered to do so. Because a lot of times when healthcare practitioners or clinicians speak to you, a lot of times for years, they've been seen as the authority, quote unquote. I'm a retired occupational therapist. So we as the clinicians were seen as the people that knew best. But thank goodness we're coming to learn it's the people with lived experience. These are truly the subject matter experts, and we need to dial in and truly deeply listen to what they're sharing. Thank you, guys.
Thank you, Connie. Paxton, anything you want to add to that about sitting across from providers and being told you're fine when your body's telling you something else?
Absolutely. Yeah. That's probably, when it really, what it boils down to with the experience of women and girls with bleeding disorders, I think that's the biggest like takeaway, that's oftentimes the shared experience of having someone else tell you, even though you're the one who's in that position and, in your own shoes, that you're fine. So, I mean, with healthcare professionals, like, of course it's not universal, but there are those out there who will say, girls bleed, that's a normal thing. It's not a big deal. And obviously the people who actually live it can argue with that and say that that's actually very different when you're the one who's experiencing that. I think that a big part of it is, and we've said this, but you're fine because you have to be fine. So I'm told by a healthcare professional, you're fine, don't worry about it, it's okay. And I'm fine in the sense that, yes, I can go through my day-to-day activities, but what's my alternative? That I quit, that I don't do my schoolwork, that I don't complete the assignments and pass the grade to go to the next grade, all those kinds of things. And I think part of it too is just not being afraid to start over. So and again, it's tying back into the women and girls with bleeding disorders, but also being someone with a rare disorder that took years to diagnose, and somebody who has undiagnosed conditions too, of not being afraid. Okay, this specific provider isn't working out. We go to the next one. We go to the next test, the next blood test, the next hospital or research institution that will accept my samples and test them, all those kinds of things. So just, I think it's like it's a exhausting all of your possibilities sort of situation too.
For sure. Yeah, no, it's a great point though, not being afraid to just make that, to start over. It can be annoying to start over, but sometimes that's just the best next move, and the sooner you can do it, the better. I should have also mentioned, Paxton is a college student studying biochemistry and molecular biology. He's also a member of NYLI. So I think that background gives attendees some more context for where you're coming from. I did say I wanted to go to Ivan, and then I have something after that from Mosey and Mark. But Ivan, we talked a bit about being a father earlier. And as we talk about how do we challenge this I'm fine mindset, as a father, how do you protect against the I'm fine mindset being adopted by your kids?
Well, for sure, you got to establish a relationship with your child where you got to establish trust from the beginning, from the time they're young. You have to have conversations with them. Don't judge them, when they say they feel a certain way or anything like that. Don't give negative feedback. Always look to encourage, right? And letting them know that it's okay to feel a certain way. How are we going to now deal with it and find ways of dealing with the problems? I do know that, my daughter can always come to me and share things with me, and I will always listen. It's not easy sometimes as a parent though, because sometimes that, they're saying things or going through things that you as a parent, you just kind of want to tell them what to do, but they got to sometimes figure it out on their own, and as a parent, you got to learn how to balance that, but one thing that Paxton said is, learning to advocate for themselves. You're preparing these children to be independent adults. And so as a parent, you don't want to overprotect, because then they're going to grow up in an environment where anytime they're struggling, they're not going to know how to deal with these issues. So just developing a relationship that's based on trust, no judgment, and just encouraging them and looking for ways to help them solve their problems together. And as a parent, being humble enough to admit that you also go through problems, and you sharing this with your kids. Your kids need to know that you're also a human being, that you're not this perfect person that doesn't have any problems, right? That way they know this is normal. We go through this stuff, but we can get through it together.
Fantastic response, Ivan, and kind of right in line with this part of the conversation for Mosey and Mark. Now, not thinking necessarily about our children, but about the people we work with, whether it's as a counselor or just a community advocate who's done a ton of work in this area, as Mark has. We both have had opportunities to speak with members of this community over the years, try to maybe shift thinking in this area. A comment came in too while Mosey was answering. Someone on Facebook posted, definitely my son, no matter how much pain he's in with a current bleed, ask him how he's doing. His response is always, I'm fine. He navigates life just as others with limitations. Mark, what do you say to people like him and to people who have just come to accept my life is full of limitations? I'm fine.
And so the first an observation on the conversation as far as it's gone. I may be the oldest person on the call. I'm well into my 6th decade now, and and we were. I was taught to really be closed and private. I've been living with HIV for over 40 years now, so I was taught, don't tell anyone, don't let anyone know, keep it all to yourself. And that sort of instilled an I'm fine mindset, because we were so worried in the 80s and 90s of what it would become. I guess I was sort of hoping, and maybe hope against hope, that that was a generational issue, but clearly that mindset has gone forward. The question that I like to often ask as a conversation starter is, are you who you are today because of or in spite of living with a bleeding disorder? Which I think really prompts an interesting conversation. Have we just learned to cope and adapt, or have we really thrived to achieve our goals? And so if we get beyond sort of the stigma and the privacy that we were taught in the 80s and the 90s, I think we have a real opportunity today to shift the conversation. When we talk with the generations that are following me, it's not how many bleeds did you have last year and what you can't do, but what do you really want to achieve in life? What were your goals? I wanted to go into the Foreign Service. That clearly wasn't practical when I was graduating from law school in '85. Knew I had HIV. Prophylaxis didn't exist. I wasn't going to the Foreign Service in Africa or some other developing part of the world. So I learned to adapt, but it would be important to know that is somebody's goal today. Do they want to pursue a career? And then if so, how is your hemophilia or any other comorbidities that you have getting in the way of that? So, we're moving into a generation again where we can really personalize care and help individuals do their goal setting. And it's that relationship with your healthcare provider that hopefully they're getting better skilled about drawing it out. I don't want to put all the burden on the treatment centers, but I think there's a learning curve for them as well, to understand that we really aren't all fine, and they've got to have a way to make that connection and to draw out really life goals and then learn to adapt.
That makes sense to me. Appreciate that, Mark. Mosey, curious, any responses to Mark's comment or the initial question about working with people who are, I'll say, stuck in an I'm fine mindset?
Yes, I think, and Mark kind of referred to questions, we're asking, and I think that's part of it. Similar to something Michael was saying earlier about how surveys and questionnaires, people tend to just say that they're doing fine when they aren't. We know that they aren't because we have the information about their bodies, and we give mental health screeners, and largely people will just kind of endorse that everything's going okay. And so I try to ask different types of questions in terms of, like, instead of how are you, but maybe, the last time that you had this bleed, how did you get through this, or what were the steps that you took? So, having them share an experience, and then you can hear emotions in the experience, and then we can kind of, pull from those, affirming them. Clearly, and this was kind of referred to earlier, you have some resilience, that you've gotten through all these things, and we know that there are times that you weren't fine, and so you've been through so much, and we know this, and so how did you get through? What were the steps that you took? How are you able to put this aside? And just giving them a space to share the story, and then their emotions in there, and two things that we can kind of follow up on.
It's interesting when you mentioned framing or prompting the discussion with this, talk about the last time you had a bleed, or the last time. Immediately what that did for me, Mosey, was it reminded me of the value of people seeing themselves depicted in media or on screen, where, okay, now I don't need Mosey I don't have to ask Mosey how he's doing with X, Y, or Z, because I'm going to put this film on, and I think Mosey's going to resonate with some stuff in this film. And then after this film, Mosey and I can talk about the character in the film and keep the discussion, safe at arms. It's about the character in the film, of course, not Mosey himself, but even our prior selves, our past selves. It's easier to talk about that than it is me now. As you said that, my own thought exercise, like if you ask me now, I'm fine, I'm going to start dodging. But if you ask me about me previously, I'm more likely to be more honest. And I've never quite thought about that, but I'm going to. That's one of my takeaways. We're not at that portion of the panel yet, but that will be one of my takeaways. I do have another question, but I want to first pause to see if anyone on the panel wants to get their voice in, given we've already said so much. Okay, I'm
Yes,
going to read this. Oh, Connie, get in there.
Yeah, just one thing I wanted to mention. I went to the Hemophilia Foundation of Michigan had the National Women and Teens event that they have every year. They had it most recently this past weekend, and it was phenomenal. 250 women attended that event. But the recurrent thing that I kept hearing was how difficult it is and has been for women to get a proper diagnosis. On average, it does take 16 years. For me, it took a little longer than that. And after a car accident, you know, in my mid 30s, I got a proper diagnosis. But here's the thing, giving ourselves a little bit of grace and just going forward and sharing and saying what we're going through. First and foremost, I love to say as women, and then as individuals in the bleeding disorders community, and just be open and vulnerable and share what it is we're living through. I think it'll help so much ourselves. And I think it was one of the panelists said it earlier, but even the generations that come after us as to how they see us cope, live, and deal with having our bleeding disorders, it will definitely help them voice up about their own. Thank you.
Thank you, Connie. And speaking of meetings that took place recently, we have something that came in here at the European Hemophilia Consortium last weekend. One of the speakers with type 2B von Willebrand disease explained that her attitude was that she is, quote, only mild, everything is fine, best not to cause a fuss. Can you speak to the intersection of the I'm fine mindset with what may be a minimization or trivialization of bleeding disorders that are termed mild? I think there's a very interesting point being made there about any kind of correlation between mild and perhaps all the more gravity toward an I'm fine response to things, because after all, this thing's just mild, isn't it? Mike, maybe let's start with you and then we'll see where the conversation goes from there. Any thoughts around the use of the I'm fine mindset as it relates to those who have a mild bleeding disorder? And you may be on mute to start.
Twice in one call. I can't believe it. I have some thoughts about that issue. And the first thought is this idea of severe and moderate and mild bleeding disorders being defined by a factor level is old-fashioned, out of date, and something we have to get rid of. This is something Dr. Valentino and I have been talking about, that the severity of your bleeding disorder should be defined by the type of bleeding you experience. And the type of bleeding you experience is the type of bleeding you tell us you're experiencing. So I think we as providers have to get out of this idea that everybody who has less than 1% of factor 8 or factor 9 has severe hemophilia A or B. I think the vast majority of people with less than 1% are going to end up with a severe phenotype. There is such a difference between someone who's got 1% and 5%, that whole group of moderate. They can have bleeding all over the spectrum. There can be some people who have 2% and don't bleed except if they're in an accident or they have a tooth pulled. And there are some people with 5% who have spontaneous bleeding, just like someone with severe hemophilia, less than 1%. This is specifically true, I think, for bleeding disorders other than hemophilia, where that relationship of a factor level, if it's von Willebrand's disease or a platelet disorder where we have nothing to base whether you have mild, moderate, or severe, other than what the person in front of you is telling you about how much bleeding they have. So I do think that this idea of how we teach trainees about bleeding disorders, how we talk to the families and the people that we serve about bleeding disorders when we say, well, we think this is going to be mild, so it's not going to be a big deal. We have to be really careful about that.
For sure. Go ahead, Mark.
Yeah, hemophilia, and perhaps for the other bleeding disorders as well, is a bit of a sneaky disease. We have a bleed, we recover, and life goes on, and we don't realize all of the underlying damage that might be occurring cumulatively. And then there's a whole, I don't like the concept or the term microbleeds much, but it's, it really is the hidden or the silent bleeding that we don't recognize. So it may be someone with mild disease, they might progress in sort of 10 or 15 year increments, where I with severe disease might progress in 5, but it doesn't mean that I'm fine and there's nothing going on. So, we've brought it up a couple of times. That's partly why I'm a big fan of qualitative research, because I think if we understand sort of population level impacts, both within hemophilia and in the general population, those become really great conversation starters. So I, as an individual, don't have to necessarily volunteer something, but my clinician can say, the general person or in the public or other individuals with mild disorder have reported these kinds of outcomes over 20 or 30 years. And let's talk about whether that's relevant for you. So the doctor has a way to bring it up in a non-judgmental, non-personal way. So all of the work that NHF does, NFBD.
Almost, NBDF.
Okay.
You're getting closer.
Okay.
Early days.
Yeah, if Don was here, she'd charge me $5. It's their new fundraising campaign. But all of that, the work through either community voices and research or the kinds of projects which I've been involved, I think really allow us to open up in a qualitative way with some empirical science behind it to bring this forward. We need to tell this story to take sort of the personal out of it. So I think we're all the same. It's just a question perhaps of how fast it happens and how comfortable we are or aware we are. But today there really are opportunities to change all of that if we just can get the conversation started. So.
Well, and Mark, a follow-up there. So I think it seems like the conversation started, right? NBDF, there we go, is holding this Wednesday webinar. We're all relating to this from different perspectives. So I feel confident saying the conversation's going, at least within our bleeding disorders orbit. But I have become very aware of how important, I feel almost a little ignorant saying this out loud, but it's true. I've become very aware of how important data is to actually moving things forward. Policy, standards of care, best practices, coalition building and consensus relies at some stage on data to back theses and suppositions. So you and Mike both, I suppose, can speak to this, but given the work that I know that you've done, Mark, in this area, conversations that we've had that have quite frankly changed my perspective as a person living with hemophilia on mindset. What research is happening right now that will help us learn even more about where the true needs are and how we may meet those needs in the next, say, 3 to 5 years?
Well, I will, not just a promotion because I'm involved, but the study which I lead, the global study, the probe study, one of the things that we're doing now is we're able to take the individual results, match them to population level results, and produce an individual report from those that tells that individual, these are the 3 areas where I'm different from the population level norms. And if we can make that available within the clinical registries and the patients can carry that in, it really sort of depersonalizes and becomes a conversation starter. We've been piloting this module in Canada, and it's actually working quite well to allow people to have conversations they never had. I learned to accept chronic pain, but does it really have to be that way? Do I have to give up the kinds of things that it's forced me to give up, or the decisions that I've made? Maybe I'm not going to go climb up to the 50th level of the bleachers because I know my knees are going to pay for it the next day. So I've given that up and I stay home and I watch it on my new 50-inch or 65 or whatever. They keep getting bigger, flat screen TV. So I've given up that experience. And so because of the fear of pain or the fear of a bleed, and so once you start realizing sort of the activities that you're giving up, how your hemophilia is interfering and when it's occurring in your daily life, and that's the data that can come from the qualitative research. and that hopefully through tools like Probe or CVR that the National Foundation is doing can really help us bring that forward. So integrating that with registries like Athen or the World Bleeding Disorder Registry or other kinds of tools, I think there's a huge opportunity for us to change. And today we have the treatments available that can actually do something about that. They weren't there in 1960 when I was born. Cryo, hadn't even been discovered. There was no treatment for hemophilia. But today there are a vast range. And so even understanding that we might be able to do something that was completely unimaginable, I think still is, a foreign concept to many people, because I'm fine.
You remind me of what I think Mosey said quite early on about the hierarchy of needs. And if it's just a matter of trying to feel safe and secure, I'm not going to move into a thriving mindset. My scope isn't going to open to here because I'm just trying to feel safe and secure. But once I feel safe and secure because treatments and regimens and all of these supports are there, well, then there is opportunity to take those blinders off. But I know, speaking just for myself, and again, influenced by conversations with Mark, amongst others, I've come to realize, wow, my blinders are still there. I have to work to push them away because habitually they're there and they want to step back into focus if I don't push them away again. But the more I do that, the easier that will get over time. Speaking of time, 7 minutes is what we have left. I got to throw it to Fiona with about 2. I think we've gotten through everything that was in the chat. If there's still something, this is your last call. But otherwise, Paxton, I'll go in pseudo reverse order. I don't remember the order well enough to be totally specific. I just know we have to now start with you. So as we start to bring this conversation to a close, it's a topic that's going to go on, and I will give a shameless plug on Bloodstream Podcast. We have a segment now devoted to this very topic. So if you're interested in these conversations and in contributions from some of the same people that are here, you can check that out on Bloodstream Podcast. But as we bring this discussion to a close, Paxton, what's resonating with you? What are you finding yourself thinking about as it relates to I'm Fine? What are you going to take away from this? And I'm going to ask a similar question of each of the panelists as a little sneak peek. But Paxton, you're up first.
Yeah, I mean, for me, it's I think a resounding consensus that we've kind of come to as a panel that you got to listen to the patients. You've got to listen to the people who are living this experience. There's only so much about hemophilia, von Willebrand's, factor 7, any of the platelet disorders, all those, these different bleeding disorders. There's only so much you can learn about those in a textbook or in a classroom setting, if you're a healthcare provider, or, going to different events and things like that. It's one thing to really have lived it, and to understand that it is such an individualized experience, and it's not going to present itself the same way in any two people, even if, they on paper seem identical in their bleeding disorder. So just really empowering, I guess, patients to be able to have that conversation, and to share how their bleeds may be similar or may be very different from, their brother, sister, friend in the bleeding disorders community.
Shared decision-making, personalization, I'm hearing those things. Totally agree. I appreciate you being a part of this today, Paxton. Thank you. Ivan, I'm going to go to you next and sneak preview, Connie. You'll be up after Ivan. Ivan, where are you?
Well, as a moderate that used to bleed like a severe, I completely understand how that is. Also, as a father of a female with mild hemophilia, I also know how that is. And one of the things that I can say, this will go for Dr. Michael Recht, advocacy is very important to advocate for yourself, but we know that there's some doctors that don't really care about that. They're old school. So for me, it's like, how can we make it so all these doctors at HTCs have a mandatory conference where they all come together and they all start learning about all of this? And how can we as patients also hold them accountable? How can we get them? How can we share our story? If they're not listening to us, who can we go to where we can share our story so we can hold these doctors accountable? Because honestly, the women, they're not being treated fairly the way they're supposed to be treated. And even our blood brothers that are considered moderate or mild hemophiliac. So we need to stand together to make sure that we're all on the same page. And really it comes down to the doctors understanding this as well, all of the HTCs.
I appreciate your passion and your point there, Ivan. Thank you. Connie, you're up next. Mosey's on deck. Connie, what you got for us?
What I've learned from this panel today, and even just the wonderful Hemophilia Foundation of Michigan Women's Retreat this weekend, is the I'm not fine is okay. and take it to the streets. Be an advocate. Try to help policy change and standards of procedure change at the very level from grassroots, regional, right on to national that you are. Put in the work. So with newborn screening, they'll consider bleeding disorders. Advocate for that. Advocate for women. What we do with our body, we should have a say. Advocate for that. So that's what I'm taking. Thank you. It's not fine to say I'm fine. It's okay to not be fine.
It is okay to not be fine. Thank you, Connie. Mr. Mosey, floor is yours.
Yeah, to piggyback on that, and everyone else as well, of course, whether a person is fine or not, where are you in this moment, and what can we do to help you to get there or to have more? And that can be in terms of if a person is doing okay, well, or whether or not they want to share that with me. I'm saying, okay, in a perfect world, what would you like? So I'm not questioning where you are currently. So like, previously we talked about, Patrick, going to the past and looking back is easier. Well, let's look forward and say, okay, what would you want in a perfect world in a treatment or whatever, or for your life, and so using that to kind of help them project into that, to kind of talk about what's really going on or what may be desired. And the same thing with mental health. You may be fine now, but it's okay to still speak with a professional in terms of setting goals or other things that you may want to do. So, starting there, okay, fine or not, let's look forward, let's look backward, and let's give you support.
I'm so glad you made that point about looking forward to. You're 100. I totally agree with that. An excellent point. Well said. Mark and Mike, I've left you the unenviable task of trying to get your final thoughts out in about 6 seconds each or something. So Mark, and then Mike, and then Fiona, my apologies in advance, and then we'll wrap it up from there. Mark.
Quite simply, we are on a journey. We have opened the door. It is a challenge to both patients, parents, and healthcare professionals. I think with this group, we've heard the passion that life can be better. It's been great that we've coped, but we really now need to explore the new frontier that new therapies have been made available for us.
Well said, Mike. Last word from you.
Yep, in reflection of what Ivan said, as someone who trains our future hematologists, probably my number one piece of advice is shut your mouth and open your ears. Listen to your patients. Stop trying to solve all their problems in the first 3 minutes. Listen to what's really important to them.
I can't do better than that, Fiona, so I will bring you back on. And as you return, I'll just say thank you to this awesome group of panelists. This was an extraordinary conversation. We certainly could have taken more time, but you know what? This was a great use of time. And this will be available for everyone. I think Fiona can correct this if I'm wrong, but as of Friday the 13th. So for example, if you really like that last thing that Mike just said, I did, you can share this link on YouTube. You can share it time coded to that moment. And you can go, hey, did you see this? So if there's a particular point, just one point that you want someone in your life to hear, share this video. You can share it with time code and make sure that they get this information as well. All right, Fiona, with that, I will toss back to you for our closing.
Super, thank you. I mean, really, this is, we've come far too quickly to the end of our time together. I really feel like we could listen to this panel on this subject for hours and just keep learning new and important things. So I really want to thank all of our panelists, Ivan, Paxton, Connie, Mark, Mike, Mosey, and our fantastic chair, Patrick, for the deep generosity with which you have shared your time and your expertise with us this afternoon. I also want to thank each of our audience for joining us as well. As Patrick said, this recording will be available on Friday, October 13th at hemophilia.org under the events tab. If you select past events, you will find all the archived webinars there. You can also find there the upcoming webinars in this series. Please join us next on October 25th when Matt Delaney from NBDF will share with us the updated FDA blood and plasma donation guidelines, what the bleeding disorders community needs to know. Thank you so much for joining us this afternoon and have an excellent week.
Thank you. Bye all.
Well.